Hello, good to see everyone. So the agenda today is to review the diagnostic criteria for restless legs to make sure that everyone, just to get everyone on the same page. Then discuss the various FDA-approved medications for RLS. And in particular, I'm going to focus on something called augmentation. And if you don't know what augmentation is now, you will at the end of the talk. It is an iatrogenic worsening of RLS due to what? Dopaminergic medicines. And there's going to be a strong message here about those medications and the future of RLS treatment. So, easy way to remember what the diagnostic criteria are, these urge criteria. There's an urge, or some might say a need to move the legs, that is present at rest, that's the R, gets better while moving. When you go back and sit down or lie down again, it comes back, but while moving it gets better, and is predominantly present in the evening or at night. There are a couple of mimics of RLS, akathisia, neuropathy, paroxysmal, other movements of the legs, periodic leg movements of the legs, but RLS is URGE, very easy to remember, and you just go through those with your patients. In terms of screening somebody who may sleep poorly at night, one screening question. You don't have to go through urge yet. Screening question. Do your legs bother you at night? If they say no, don't bother going through URGE. If they say yes, you got some work to do. Maybe it's RLS, maybe it's something else. Okay, in terms of sleep disorders, I'm a sleep disorders doctor. I've been seeing sleep patients for 30 years and see all kinds of sleep disorders patients. You can see in terms of prevalence, RLS is the third most common. Insomnia is clearly the most common, sleep apnea next. About 2.5% of adults have clinically significant RLS. Clinically significant RLS that occurs at least twice a week and is at least associated with moderate distress. 2.5% of adults. So if 2.5% of your patients don't have RLS, it's not because they don't have RLS. It's because you're not asking. If you don't ask, you don't know. Clearly the secret in medicine. We often divide RLS into these primary and secondary forms. I'm not sure that it makes that much difference because the phenotype is identical. But we want to think about these secondary forms, comorbid disorders where RLS is more common because many of them are reversible. No one with restless leg syndrome leaves your office without having a lab slip for iron, TIBC, and ferritin. So iron deficiency has nothing to do with anemia. Here we're talking about iron that is not involved with the red blood cell. This is brain iron we're talking about, which is not easy to access, obviously, but peripheral iron gives you some insights. Renal failure. People with renal failure have a higher risk of restless leg syndrome. About a quarter of women in their third trimester will have restless leg syndrome. Then you can see other associations, particularly serotonergic antidepressants, and I've studied people who are in opioid withdrawal who commonly have restless legs during the detoxification process. Not a surprise, opioids treat RLS, opioid withdrawal causes RLS. So when I see people with RLS, the first thing I'm going to do is assess the temporal distribution. I divide the day into 4 parts, and I say, I'm going to ask you about each of these parts in turn. So from the time you wake up, it's 6 or 7 in the morning till noon. How many days a week do you have it? How bad is it? From noon till 5 or 6 p.m., how many days a week do you have it and how bad is it? So you can have a picture of the temporal distribution. I see many people referred by neurologists and they're on a dopaminergic TID. I say, why are you on this medicine 3 times a day? Because you've never had symptoms in the morning, never had them in the afternoon. Why are you on this medicine TID? I don't know, that's what my doctor told me to do. Why? That's the way you do it with Parkinson's disease. So you treat here focusing on the presence of medications with the shorter acting medicines. So workup, it's pretty simple. You don't really even need to do a physical examination, honestly. But the main thing is get iron indices. You want to look at ferritin and keep it above 75. Normal limits, lower limits around 15 or 20. You want to keep it much higher than that. You want to have more of a push from the periphery into the brain because it's really brain iron that matters. And transferrin saturation, which is iron divided by TIBC, should be more than 20. You want to think about medications. Serotonergic antidepressant. 10% of adults in the US on a serotonergic antidepressant. Dopamine antagonists and narcotics. Antihistamines should be on there. Antihistamines provoke RLS. Also, alcohol provokes RLS. Talk to anybody with RLS, they say if I have a drink, have a glass of red wine, it's really bad that night. Physical examination, you want to assess for neuropathy to make sure there's not comorbid neuropathy. You want to look in the upper airway. Do a Mallampati examination and see how crowded it is there because sleep apnea is going to worsen RLS. You want to think about whether they also have insomnia. And we really don't need to do sleep studies in these people. I love sleep studies. I love sleep studies more than everybody in the room combined. I read 1,000 sleep studies a year. They're relaxing, they're fun, they're instructive. But for people with RLS, unless you suspect a sleep-related breathing disorder, it's really just a waste of time. So when I talk to patients, I put up these 4 fingers. There are 4 classes of medicines that work for RLS, which is really nice because we've got a number of options. They're the calcium channel alpha-2 delta ligands. We'll talk about each one of these in turn. The dopaminergic agents, the opioids, and iron. 4 classes. So it's not unlimited, but we've got a bunch of options. So here you can see there have been a number of guidelines released. The American Academy of Sleep Medicine released their last one in 2012. We're revising that now. It's nearing the end of that process. I was the first author here, as you see, on the AAN guidelines, published in 2016. We don't have to go through all the details of this, but you can see we did not evaluate medicines based on first line, next line, kind of in an algorithmic perspective. We really just looked at it from meta-analyses. So FDA-approved medicines. The first one, Rapinirole, Requip, came out 18 years ago. I was in high school at the time, so I really don't remember it that well. But then a year later, Pramipexole came out. This is 5 to 10 years after their approval for PD. Obviously, the dopaminergic drugs are used at a much lower dose than they are for PD. So Rapinirole, no more than 4 milligrams. You're above 4 milligrams with a Rapinirole, as we will see. That's a sign there's something wrong, and you need to reassess. Pramipexole, above 0.5, there should be a blinking red light, or maybe even a fixed red light. There's a problem. Gabapentin nenocarbol, approved in 2011. We'll talk about that in a minute. And Retigatine, a dopaminergic agonist patch a year later. So a little bit of history. I wrote this paper, one of the first papers describing augmentation back in 2004, describing this process that we'll be talking about where using dopaminergic drugs makes RLS worse. You've all seen it. Whether you recognize it, I don't know, because it happens in the majority of people on dopaminergic drugs for RLS. What's really kind of embarrassing to me is the last sentence. Augmentation intolerance are more common with extended, longer term pramipexole treatment of RLS than has been previously reported in preliminary studies. Preliminary studies suggested it really didn't happen. If you don't think of something, you don't ask about it, you don't see it. We all know that's the secret in medicine, right? However, these complications are generally manageable by earlier dosing or small dose increases of this agent, and only rarely require medication documentation. If a human could put their tail between their legs, I would be doing that now. This is wrong. And it was my understanding at the time. I was also the first author on the pivotal trial for the approval of pramipexole Mirapex for RLS in 2006. 12-week trial, works really great for 12 weeks. But I was naive. Why would we do a 12-week trial for a medication that people are going to use probably for the rest of their lives? How does that make sense? Exactly. That doesn't make sense. So 2 years later at the NIH and the Restless Legs Syndrome scientific meeting, I was already peeved by my naivete and started railing about this. And I said, clinicians have become addicted. We became addicted to the predictable, rapid, and nearly complete response of our patients to these medicines. They're incredible in the short term, right? Like putting butter on a hot pan. Symptoms just go away. The problem is if you continue to follow these people, response wanes, and we'll see about that. They're addictive in the respect that they create a need for medicine at times you didn't need it beforehand. You need increasing doses over time, and if you try stopping it, you have terrible rebound. Dopaminergic agents for RLS are addictive, and our job is to not get our patients onto medications which are going to satisfy us and them in the short term, but not in the long term. So what is augmentation? And you can see the different parts. On the top there, appear earlier in the day. Symptoms expand temporally. They used to only start at 10 o'clock. You gave your Mirapex at 9, everything was hunky-dory for a year. Now they come back saying, you know, symptoms are starting at 6 o'clock. You go, okay. Why don't you take some at 5 and some other one at 9? That'll take care of it, right? Now you've probably doubled the dose. A year or two later, they come back and say, Doc, that was working for a while, but now, like, if I try to sit down 2 o'clock in the afternoon, my legs are bothering me again. Temporal expansion. There's anatomical expansion as they go from the legs to the upper extremities. And upper extremity restless legs is not so easy to get rid of just by walking. So people doing this kind of stuff, it's unfortunate. The symptoms are of increased severity, and they happen more quickly when you're sitting down, resting, or lying down. This is augmentation. Like everything else, or like many things, it exists along a continuum. First, they lose efficacy. The same dose that was working before now stops working. You have to increase the dose. Then they start having earlier onset of symptoms. Then they start having earlier and earlier onset of symptoms. And then they've got symptoms 12 to 16 hours a day. And we, as providers, are responsible for that because we kept giving them more at other times of day. So, it should be clear by what I'm saying that dopaminergics are no longer first-line treatments for RLS. I expect that the American Academy of Sleep Medicine guidelines will come out saying this. Certainly, the guidelines that we released 2 years ago now in Mayo Clinic proceedings suggested that as well. You should not be going to these medicines as first-line treatments. It's easy. It makes everybody happy in the short run. That's fine, but say to the patient, I'm going to give it to you now, but I don't want to see you again because things are going to be bad next time we meet. And that's probably not a great way to practice medicine. So I did a study where I looked at drug utilization in the United States. Basically had 1 million providers, the majority of providers, healthcare providers in the United States. Over, 1.2 million. 670,000 people were getting medication treatment for restless leg syndrome. Nearly 60% of them were on dopamine agonists. This covered the years, I think 2017 to 2018, if I recall. So it was an enormous resource. IQVIA, people have heard about IQVIA. They've got all of our data. You know exactly what we're prescribing and to whom. And you can access the data if you pay for it. So we had de-identified patient data, but we got individual prescribers' information and then collated it. So 60% of people treated for RLS are getting a dopamine agonist. About 20% of those people getting a dopamine agonist for restless leg syndrome were taking doses that were above what the FDA recommends as the maximum dose. How do you get to those doses? You don't start at those doses. How do you get there? It begins with an A and ends with an N. Right, it's augmentation. That's how you get there. So, think before you prescribe these medicines. Calcium channel alpha-2 delta ligands, there are 3 of them available. Only one of them is FDA approved. That's gabapentin and acarbol, also known as Horizont. There's also gabapentin, old-fashioned gabapentin, and pregabalin, old-fashioned Lyrica. You see they have potential side effects as well. Most commonly going to be sedation, dizziness, gait instability, weight gain. There is no evidence of augmentation with the alpha-2 delta drugs. We did a study, I was senior author on this, published in the New England Journal of Medicine in 2016, I think, head-to-head study of pregabalin versus pramipexole. And it was blinded and placebo for 12 weeks. Then placebo got re-randomized to the others, and we followed them for a year, and we were looked, and the lead authors looked blindly to determine if there was augmentation, and augmentation existed in a dose-like fashion for the dopaminergics and was not present for pregabalin. The alpha-2 deltas do not produce augmentation. So what is it that makes gabapentin and acarbol different than gabapentin? There may be some confusion about this. And the confusion exists because when, I can't remember who it was, came out with Neurontin, they didn't make clear that it had non-linear pharmacokinetics. I hope people are comfortable with that. That bottom line there is non-linear pharmacokinetics. You double the dose, you think you're going to get double the serum concentration. But look what happens after you get up about above 400 milligrams. You give more, but the receptors in the gut can only absorb so much. So if you want to get higher serum concentrations of gabapentin, you have to give 400 to 600 milligrams and split the dose every couple of hours. But given 900, 1200, 1800 all at once, most of it is going to end up in the toilet. I say to people, you can take the 600, take the other 1200, and just throw it directly in the toilet. Don't bother swallowing it because it's not going to get absorbed. If you wanted that to get absorbed, split your dose. On the other hand, gabapentin and acarbol, this Horizont, has linear pharmacokinetics because it's a prodrug. And the medical scientific term is it's got a little goober on it. And I don't know what that thing is that's attached to the gabapentin molecule that allows it to get absorbed directly. It gets absorbed into the bloodstream from the lumen of the GI tract, and then that's cleaved. Now you've got gabapentin. So you get linear pharmacokinetics. What you give is what Okay, alpha-2 deltas. Now we're going to talk about iron. Remember, every person who comes in your office with restless legs, ferritin, iron, TIBC. The iron, you need to ask them, are you taking iron pills? If they're taking iron pills, they really should wait 24 to 48 hours before getting their blood drawn, because otherwise you're getting iron pill that you're drawing up in your syringe. And similarly, no red meat for 24 hours beforehand. You want their iron level. You don't want a hamburger level from lunch. So iron, ferritin, TIBC, if they're below these levels that I talked about, 75 of ferritin, 20% of transferrin saturation, you can give oral iron if the ferritin is low enough. If it's in that range above 50 of ferritin, they're not going to absorb the oral iron, so you have to give it IV. And there's good clinical trials of PO iron in people with low ferritin levels and IV iron in people with ferritins up to about 100. You want to give 1,000 milligrams of iron of some formulation. Probably doesn't matter what formulation at this point. They're all really safe. IV iron is very different now than it was 20 years ago, where you had these higher rates of anaphylaxis. It just really doesn't happen, or rarely happens now. And you can see here, this is from Lancet Neurology in the lower right. And you can see, interestingly enough, you think IV, it's going to work immediately. But look at the red line, which is the reduction in symptoms compared to the blue with IV iron, compared to the blue line, which is saline. And they were blinded. All the patients and investigators were blinded. And you can see at 12 weeks, from 8 to 12 weeks, it was still getting better. Some process we don't understand takes time to get the iron into the brain or working in the brain. Let's talk about opioids for restless legs. When people fail alpha-2 deltas, fail iron, and you don't want to give a dopamine agonist, or when they're on a dopamine agonist and they're augmented, opioids are your treatment. So there's a variety of opioids that you can use for restless leg syndrome. As you can see, much of what differentiates them is half-life, and I've kind of gone from shorter half-life to longer half-life here from top to bottom. We'll talk about that more in a minute. Most of you are saying, opioids, are you insane? I'm not going to prescribe these medicines, and if you believe that, you're like a lot of other doctors in the United States. Here's data from 2012 to 2018 on the right from the New England Journal. 30% of U.S. providers during that time became non-prescribers of opioids. They would not prescribe opioids for anything. And so the pendulum has swung, really swung. You go in for surgery now, good luck. You're getting gabapentin, Tylenol, non-steroidal anti-inflammatory, but you're not getting opioids. So people are afraid, docs are afraid to prescribe opioids. And it really is a balance of fear versus care. Our fear about harming our patients, our fear about our own license and liability versus taking care of the patient. I can tell you that the way to prescribe opioids safely is to think about these 3 C's. If you're not one of these 3 C's, you can prescribe opioids. But don't prescribe them if you are careless, corrupt, or compromised. These are the people who are getting in trouble prescribing opioids. You're allowed to prescribe opioids. Opioids are within your medical license. There's certain safeguards, but I prescribe them all the time, and it's fine. And for people with restless leg syndrome, it's transformative. And as we'll see, these are very low doses. In fact, I'll just go back. Generally, the usual dose, the most common opioid I use is methadone. Generally, about 10 milligrams, 7.5 to 12.5. I have people on 2.5. I have the rare patient on 17.5, 20. Never go above 20. It's usually 7.5, 10 milligrams. Very low doses. Buprenorphine, smallest pill or film is 2 milligrams. I have people cut it in quarters. These are very low doses that people are very exquisitely responsive to. Before you start an opioid, the opioid risk tool over here on the right is a screening method to assess the risk that people have of misusing or abusing the medicines. Do they have a personal history of substance abuse or use? Do they have a family history? Are they younger? Do they have a history of psychiatric illness, et cetera, et cetera? The PMP, people have PMPs wherever they're coming from around the country that you can access, right? Yes? I love the PMP. I mean, it's a fantastic resource. Prescription monitoring program. You can see whether people in your state, the state has a database of all controlled substances that are prescribed. So if you have any worries about whether they're getting it from somebody else, doctor shopping, click, you can see. Sometimes I do a urine tox, but usually not. Only if I really am suspicious. And Mass General requires us to sign an opioid agreement, which says that patient says, I'll use it appropriately, doctors, these are the potential side effects, et cetera, et cetera. You write on the prescription for chronic RLS pain. That way you can write for methadone in these very low doses, and they're not going to a methadone clinic, they're getting it for pain. Never had a problem for chronic RLS pain. Buprenorphine, Suboxone, you do not need an X license anymore. Again, write for chronic RLS pain. And you write one dated today, one dated a month from today, and one dated 2 months from today. 3 months, and you're covered. They're covered. I mean, and you can do the same thing we do it on Epic, you can do it in your electronic medical record. So, just like it is with any of the other treatments, whether it's the alpha-2 deltas or whether if you insist on using dopamine agonists, you base your treatment on the timing of symptoms. Don't give a medicine in the morning if they don't have symptoms in the morning. It's a waste. So you ask those questions. When are you having it? Get your temporal distribution. Since opioids differ predominantly or significantly in their half-life, think about what area what time you want to cover. So if they just have symptoms at night, at bedtime, I might use a short-acting opioid like oxycodone, tramadol, hydrocodone. Generally, the people that I see don't just have it 2 to 4 hours a day. But you may see them in the community or in a university setting. If they've got it at bedtime in the first half of the night, then you can use a controlled release, an extended release form of oxycodone. Most of the people that I see have symptoms 10, 12, 14 hours, 16 hours a day. So I'm going to use, and the vast majority of my patients are on a long-acting agent, methadone or buprenorphine. Low doses. So quickly, I don't want to talk too much about this data. Because I felt that I was burned by the dopamine agonists, I wanted to make sure that opioids would not produce tolerance, loss of efficacy over time. Previous smaller studies suggested that they did not, but they were too small. So I got funding to do a registry, a longitudinal observational study. Enrolled 500 people around the United States from all different providers. Many of them came from the Restless Leg Syndrome Foundation. Roughly 50% were on methadone, about a quarter were on oxycodone. Wide range of ages. They had to have had a previous therapeutic response to a dopamine agonist. I wanted to make sure they had RLS, because everybody with RLS really responds almost to dopamine agonists. And we interviewed every single one of them by phone, and they were taking daily opioids for a mean of 1 to 3 years. beforehand. Mean MME was 30. So that's 7.5 milligrams of methadone, 20 milligrams of oxycodone per day. And here's some 2-year longitudinal data that's just coming out in Neurology, published online just a couple of months ago. I'll direct your attention towards the right. And you can see over the 2 years that we've been following people, the majority of people, 60% of people, had no change in their opioid dose. But you can see that about 30% did have a change. Most of those people had an increase of about 0 to 10 MME, so that's 2.5 milligram increase of methadone, 6.5 milligram increase of oxycodone. What we were most concerned about and interested in are the people who increased their dose substantially. That's what you want to know about, right? Who's going to be that person who I'm going to give this small amount and it's good, and 2 years later they're blowing up in my face? And they're wanting more and more and more. Why is that? Who are they? Can we probably avoid prescribing these to those people? Because the majority of people are using low doses and staying at low doses. So when we did this regression, most common reason that people were increasing their dose substantially, an MME greater than 50 increase, they were using opioid for a comorbid pain condition. And we know that opioids work only for a time, and then you have to keep increasing it in pain conditions. Another strong predictor was people who were also taking a dopamine agonist, and during this interim, the doctor or the patient had stopped the dopamine agonist. So when you had two things helping with the RLS and you took away one of them, so you need to increase the agonist, the opioid, while you're decreasing the agonist. Then younger age, male sex were important ones. But you can see here, baseline median, 2-year median, methadone 10, 10, oxycodone 10, 10, hydrocodone 10, 10.6. Most people really did not change their dose. We're going to continue doing this study, this registry study, until I die or until everybody in the registry dies, as long as I keep getting funding for it. So, managing augmentation. This is the biggest issue in current RLS practice. Most docs, in my experience, what they do when patients stop responding or have earlier symptoms, just say, okay, take 2 of them. Okay, take that one and then take another one earlier. Yeah, I know you're taking those 2 at 6 and 9. Start taking 1 at 2. So when you're giving a dopamine agonist, you start digging a hole. This is from Will Rogers, this quote. Anybody's heard of Will Rogers? Start digging a hole. And over the years, you're digging and digging and digging, and pretty soon you find that you're in the hole over your head. And that's when the people come to me, and I try to get you out of the hole by switching you to an alpha-2 delta agent or an opioid. So another analogy, if you will, giving dopamine agonist or more dopamine agonist to RLS patient is like you think it's water, you're putting out the fire of RLS, but it's gasoline. So people getting worse, check their iron. Always check their iron. I can't tell you how many GI cancers I've picked up just doing this. Because ferritin's dropping, or you've given them IV iron, and then very quickly they get iron deficient again. Look at their meds. We've gone through this before. Comorbid sleep disorders. Maybe you're giving the medicines at the wrong time. Because again, sleep study, probably not necessary unless you think they have sleep apnea. Mild augmentation. Okay, they're having symptoms a little bit earlier. Maybe you want to take your original dose and try to split it. Maybe you want to take your short-acting agent. Augmentation happens rapidly with levodopa. Super rapidly. And this has been known now for more than 20 years. If you're using a short-acting agent, dopaminergic drug, maybe you could go to an ER, pramipexole ER or Pinerol ER. I don't recommend it because augmentation just continues to happen. The process, that plasticity in the dopaminergic system keeps happening, even with the extended agents. If you notice that they're above FDA maxes, above pramipexole 0.5, above ropinirole 4, above retigatin 3, it's a bad sign. It's an indication that something bad is going on and you're on the wrong path. Look at the iron, give them some iron. You can maybe keep the dopaminergic dose low and add gabapentin, one of the alpha-2 deltas, gabapentin and a carbol, gabapentin pregabalin, to try to rescue that low dose of the dopaminergic. It's not my first choice. The goal is to get them off the dopaminergic by using one of these other medicines, because the augmentation process is happening in the background. This system is a very plastic system. So to reiterate, if you find yourself in a hole, stop digging. If you find that these approaches to the mild augmentation aren't working, you need to do something more radical. And I have the conversation with people. Look, you know and I know that this dopaminergic medicine is not good for you at this point. And they realize it, but they're terrified about stopping it because they ran out one night. They couldn't get to the pharmacy in time. They didn't have it. And they know what happens when they stop it. Symptoms are terrible, so they're terrified about changing that dopaminergic drug. It's like a bad relationship. You know, there's a honeymoon period at the beginning, but then one of the members in the relationship becomes abusive, but it's hard to get out of it. And you have to say to them, I'm going to get you out of this. You'll see what I'm going to say. We're going to add something else that treats it, and then very gradually we're going to remove the abusive drug. So in order, make sure all the other things are under control. Iron, sleep apnea. If you can change this serotonergic antidepressant to bupropion, that would be lovely. If not, don't mess with that. Add and maximize the alpha-2 delta. Okay? You add before you subtract. Gabapentin and a carbol, gabapentin pregabalin. Add, get it up to the maximally tolerable dose. That hopefully should start controlling the symptoms. Then you say to the patient, it's time. Symptoms are better. You're doing better, right? Now it's time for us to remove this dopamine agonist. And you do it slowly. Don't do what I see a lot of docs do is they know the dopamine agonist is a problem, and so they say, look, I'm going to start this alpha-2 delta agent, and at the same time I want you to stop your dopamine agonist. So all that they get then is the experience of that terrible rebound, and they blame it on the alpha-2 delta. Oh yeah, that gabapentin or gabapentin and a carbol or pregabalin, that was terrible. It made my symptoms so much worse. They were so much worse because you told them to stop the dopamine agonist at the same time. You add first, then very gradually, and I mean super gradually, 3, 6, 9, 12 months, chipping away at that dose. If the alpha delta doesn't control symptoms by itself, I will then, and so now they're on the dopamine agonist and the alpha-2 delta, I will now add the opioid. So now they're on 3 meds for they say, 3 meds for restless legs? I say, yeah. This is how we're going to get you off of that dopamine agonist, which is making trouble for you big time. You know it. Add those. Add the opioid. Now go back, start getting rid of that dopamine agonist. Then you can probably try to taper off the alpha-2 delta. Or keep some of each, your call. So first add, then reduce, okay? Pretty simple. So we published a paper last year testing the guidelines for how to manage augmentation. They're published guidelines that I was very involved with, and I wanted to know, do these work or not? And so I looked at a whole bunch of my patients over the past few years who I had followed these guidelines for. 84% of them came in at the initial visit with moderate to severe disease based on the CGI severity scale. At the final visit, which was about 2.5 years later, I mean, not final, they didn't die, but before our analysis, 2.5 years later, following this guideline, now only 24% had moderate to severe illness. Some of them, we were still working on getting rid of the dopamine agonist or maximizing the other medicines. But we had to pick some time when we did the analysis. And more data saying 78% were much or very much better in the CGI improvement scale. In terms of responders, those 78% were only borderline to mildly ill at the last visit before analysis. They were doing a lot better. Not everybody could stop the dopamine agonist. It's really hard. I mean, I used the addiction word because they just couldn't do it. They kept having this rebound as they stopped it. The average time to discontinuation of the dopamine agonist was 9 months. You have to be patient, and you have to tell them, you're going to need to be patient, and we're going to do it very gradually. So about 40% of people could stop the dopamine agonist with just the alpha-2 delta. The other 60% couldn't stop the dopamine agonist just with the alpha-2 delta, either because of their lack of efficacy, the tolerability of that class of medicines, or a combination. But that's your first go-to. Add the alpha-2 delta and start chipping away at the dopamine agonist, little by little. Say to them, I want you to take 0.125 of pramipexole less every month. Every month. The first week is going to suck. You're not going to sleep well. You have to warn them about that. But then it'll get back to where you are now, which is not great because you're augmented, but little by little. I'm not going to do that. If you want a how-to, I got asked by the editors of this journal, Chest, which is a really nice, prominent, high-impact factor journal, to write something about treating severe refractory and augmented RLS for this section, How I Do It. So how I do it. And so this is a really play-by-play here on how to manage these people with severe RLS, and it really gives you guidance. And so I looked that up. It just came out 6 or 8 months ago. In conclusion, assess patients for underlying contributors. Iron is the key one because things don't work very well if they're iron deficient. Nothing does. Obstructive sleep apnea, if you think they might have that. Serotonergic antidepressants, antihistamines, centrally acting antihistamines, dopamine antagonists. For people who are treatment naive or for people who are augmented, start with an alpha-2 delta calcium channel ligand. Gabapentin and a carbyl, gabapentin, pregabalin. If you're using a dopamine agonist, if you are the one addicted to this drug because you're most comfortable with it, if they're on a dopamine agonist and they are augmented, the goal eventually is to get them off of it. And as we've talked about, we do that by adding the second agent or even the second and third agent to the dopamine agonist and then gradually reducing the dopamine agonist over time. And they're so grateful when they're off of it because they know that it was a problem. It was making it worse. It was just gasoline on the fire.